Very good morning, respected Vice Chancellor Sir, Principal Sir, esteemed faculty members, colleges and dear residents. I welcome you all today for this CCR by Department of Physical Medicine and Rehabilitation. Today, our topic is when pain disease. It will be presented by Dr. Himanshu Ahuja, Dr. Ragdhara Mishra from Department of Physical Medicine and Rehabilitation, and Dr. Ankit Beniwal from Department of Medicine, and Dr. Shilpa Maharia from Department of Physiology. Today is World Persons with Disability Day, International Day for Persons with Disability. So let's work together for eradication of disability. So, what is physical medicine? Brief introduction to physical medicine and rehabilitation. Physical medicine rehabilitation, PMR, also known as physiatry, is a medical specialty that involves restoring function for a person who has been disabled as a result of a disease, disorder or injury. Physiatrists or PMR provide integrated multidisciplinary care aimed at recovery of whole person. Rehabilitation is the process of helping a person achieve the highest level of function, independence and quality of life. Rehab doesn't reverse or undo the damage caused by disease or injury, but rather help restore the person to optimal health, functioning and well-being possible. In our hospital, department was started in June 2020. It is now approved. It is located in main hospital building. It is approved for 2 seats, MD seats. First batch started from 2021. Presently, we have 2 professors and 1 assistant professor as faculty with 4 residents. Among supportive staff, we have 2 physiotherapists, occupational therapists and nursing staff. Our daily OPD load is around 15 to 20 patients per day. We have various facilities available, including biomechanical assessment like gait lab and posture assessment lab, foot pressure analysis lab, and various injection procedures like ozone, PRP, trigger point injection and Botox, and advanced physiotherapy and occupational therapy facilities. This is one of the video of an IPL player, Athar Taide. We did gait assessment of Athar Taide, both dynamic and posture assessment. We have wireless EMG and foot pressure plate for biomechanical assessment. Now I'll request Dr. Ragdhara to start today's case presentation. Thank you.
Good morning, respected dignitaries, esteemed faculty members, and my dear colleague residents. I'm Dr. Ragdhara Mishra from Department of Physical Medicine and Rehabilitation, and I'll be starting with our case discussion. So today, let's dive into what happens when pain misleads us and how a hidden culprit quietly mimics the disease. Starting with the history, we have a case of 58-year-old female, a homemaker from middle socio-economic status, residing at Sri Ganganagar, who came to PMR OPD with complaints of upper back pain, which is associated with neck pain and reduced range of motion of shoulder, pain in thighs causing difficulty in walking, and functional limitation during daily activities since past 12 months. The pain began gradually as dull aching with generalized early morning stiffness, which lasted for approximately less than 20 minutes and has progressively worsened in past 2 months. The pain radiates to the neck, right forearm and hand with tingling sensation. It gets aggravated with shoulder movements and overhead activities. The pain is associated with reduced shoulder range of motion, fatigue, headaches, reduced vision and reading ability from past few weeks. She also reports pain in thighs bilaterally along with reduced tolerance of walking, causing limitation of activities of daily living. She also reported history of treatment for rheumatoid arthritis and has been on disease-modifying anti-rheumatoid drugs, that is DMARDs, for the past 8 years, including methotrexate and hydroxychloroquine, with intermittent NSAIDs and steroids during flare-ups. There was generalized joint pain, but no joint deformity or swelling visible to her. She reports that her shoulder pain and reduced mobility have worsened gradually over the last 2 months despite continuing her regular medications. The patient reports of no trauma, no fever or infection, no weight loss or any systemic symptoms, no cardiopulmonary or neurological complaints, no past history of TB or thyroid disease. Under past medical history, she's been a known case of generalized body pain and weakness for past 8 years, having poorly controlled type 2 diabetes mellitus and history of chronic anemia and hypertension. In past drug history, she's been taking DMARDs and gabapentin for pain, telmisartan for hypertension, and occasionally proton pump inhibitors for gastritis. There were no significant past surgical history or hospital admissions as mentioned by her. She follows a vegetarian diet with normal appetite, has sleep disturbance due to pain and reduced activity, normal bowel and bladder habits, no addictions. She is postmenopausal woman with no abnormal bleeding, and her family history is negative for rheumatoid arthritis, diabetes, hypertension, thyroid disorders, or any kind of hereditary disorders. So until now we have gathered the information that a 58-year-old female with upper back pain worsened from past 2 months, radiating to the neck, forearm and hand with reduced shoulder movements, being a known case of generalized body pain since past 8 years, on regular DMARD therapy, and has poorly controlled diabetes. This pain is affecting sleep, daily household activities and walking ability, along with progressive limitation in functional activities over recent weeks. Based on the patient's history, what possible diagnosis come to your mind first? Any guesses? Yes? Anyone else? Okay. As we saw, her symptoms push us to consider multiple systems here. So we can have possibilities like nerve entrapment syndromes, C5-C6 radiculopathy, migraine, musculoskeletal pain, or rotator cuff injuries. Coming to general physical examination first, patient was conscious, cooperative and well oriented to time, place and person, moderately built and nourished. She was vitally stable without any pallor, icterus, cyanosis, clubbing, edema or any kind of lymphadenopathy. In systemic examination, multiple systems were assessed and there were no specific abnormality detected according to the history of the patient. Coming to clinical examination of upper limb, on general inspection, patient had a forward head posture with rounded shoulders. Musculoskeletal symmetry was assessed and the responsible muscle groups like trapezius, deltoid and supraspinatus, they appeared symmetrical with normal skin folds and stance. There were no visible trophic skin changes, no erythema or swelling present which could be suggestive of any inflammatory pathology. On palpation, temperature and tenderness were assessed first, so there was no local warmth present. Tenderness was graded on 0 to 4 scale for trigger points according to the soft tissue tenderness grading scale as mentioned on the slide. The patient had grade 3 tenderness over the right upper trapezius and levator scapulae, grade 2 tenderness at scalenus and supraspinatus muscle also on the right side. Palpation revealed palpable taut bands in the upper trapezius and supraspinatus muscle with positive local twitch response. And these trigger point palpation reproduce her characteristic referred pain pattern radiating to her right hand and arm, which she mentioned in the history. On assessing the shoulder range of motion, flexion, extension and abduction was markedly reduced on the right side if we compare it to the left side, and it can be seen due to pain at the end range in flexion, tightness noted in the posterior shoulder while extending, and pain in the mid range associated with trapezius guarding in case of abduction. External rotation was limited to 45 degrees on the right side, 60 degrees on the left, and this producing pain around the supraspinatus and infraspinatus region. And internal rotation was 50 degrees on the right side, 60 degrees on the left, with posterior shoulder pain during movement. On cervical range of motion assessment, flexion and extension were significantly limited. Lateral flexion was painful on the right side and reached only 20 degrees, while left side it reached 30 degrees. Cervical rotation was also markedly restricted. On power testing, the right upper trapezius, supraspinatus muscle and infraspinatus showed mildly reduced strength at 4 minus by 5 due to pain, and left side showed similar 4 by 5 strength. On special test for shoulder, knees test was mildly positive on the right side, whereas Hawkins-Kennedy test and MTCAN test were also negative. There was only mild pain on the right side due to upper trapezius guarding, hence lesser chances of impingement or rotator cuff injury in the shoulder joint. The cross-body adduction test was also negative to help us rule out any acromioclavicular joint pathology. A few specific tests were positive, like jump sign with palpable trigger points in the upper trapezius, levator scapulae, scalenus and supraspinatus muscles.
think when you're naming all the tests,
Yes, sir.
you're talking to a lay audience. Maybe you could just mention what the test involves, because just having Neil's test, Hawkins test, negative,
Yes, sir.
doesn't convey any meaning at any point of time.
Yes, sir. So as I mentioned, Neese test, Hawkins-Kendi test, and MT-Ken test, they were mildly positive because of the trapezius guarding. So these were to rule out any kind of impingement syndromes or rotator cuff syndrome, which are usually positive in these
So
cases.
my knowledge, Neil's test would be something like coconut water Neil. So
Okay.
I mean, just names do not serve a purpose. You are aware of it because it's a day-to-day thing. But I think for the rest of the audience, you need to be a little bit more clarified.
Okay, sir. On cervical and neurological examination, Sperling's test, this produced mild right-sided pain without any radiation to rule out any kind of nerve root compression, which can be seen in the image. And cervical distraction test was done, which did not give any kind of relief, indicating the pain was of muscular origin. Neurological assessment was also done, which showed intact sensation, normal reflexes, and no motor deficits, effectively ruling out any cervical radiculopathy. On functional testing, she experienced pain during overhead activities due to increased right trapezius load, and even lifting a 2 to 3 kgs object triggered her pain within seconds. Next, coming to general examination of lower limb. On general inspection, the patient showed an increased anterior pelvic tilt of approximately 12 to 15 degrees due to hip flexor and adductor tightness. Knee alignment was normal without any deformity. She had a pain avoidant slow gait with early fatigue along with reduced push off due to limited hip extension bilaterally, which is according to the normal walking stance. On palpation, there was no warmth or swelling around the knee, but significant tenderness was noted in case of adductor muscles bilaterally, quadriceps, especially varus medialis and lateralis muscles, medial and lateral hamstrings muscle, and gluteus medius showed mild tenderness. Palpable taut bands were also present in adductor longus, varus medialis, and hamstrings muscle. The hip range of motion assessment showed limited flexion with anterior thigh pain bilaterally, reduced extension due to tight hip flexors, and abduction was restricted to 15 degrees on the right side and 25 degrees on the left side due to adductor tightness again. So adduction, external rotation, and internal rotation were also mildly restricted here, indicating globally reduced range of motion primarily due to muscle tightness. Knee range of motion assessment showed reduced flexion with anterior knee pain and limited extension, suggesting tight hamstrings and varus medialis involvement in this case. Coming to power testing, it showed hip flexors, adductors, and extensors, along with knee flexors and extensors being capable of minimal resistance according to the modified MRC grading scale, which is shown on the slide, due to painful restriction here. While functional strength tasks like sit to stand was limited to 15 seconds only due to fatigue. Normal is approximately 9 to 10 seconds, where 5 repetitions are done. And single leg stance test was observed, and it showed only 10 seconds with pain and instability, where normal according to her age, as she is more than 50 years, it should be more than 10 seconds. In muscle length testing, we could see marked adductor tightness with the knee being 5 to 10 degrees above neutral on the Patrick's test, also known as Faber's test. And we could observe positive hip abduction test, which was less than 25 degrees bilaterally in her case. Ellie's test, also known as Duncan Ellie's test, was also positive with quadriceps tightness. And hamstrings were found to be tight with positive SLR, that is straight leg raise test, being restricted bilaterally in her case. A positive Ober's test was also observed with the leg remaining elevated 5 to 10 centimeters above the table, showing iliotibial band tightness. Under special test, jump sign was positive, indicating a sudden withdrawal with pressure on the adductor muscle belly. Referred pain patterns also got confirmed here with adductor longus to medial part of the knee, varus medialis to anterior part of the knee, and hamstrings to the posterior part of the knee. Finally, rapid fatigue was observed after 10 to 15 isometric contractions in case of adductor fatigue test, suggesting a classic myofascial dysfunction in her case. This is the test, fatigue test. Next, patient showed a gait speed of about zero point 0.8 meter per second, where normal is more than 1 meter per second. Stride length is reduced to roughly 45 to 55 centimeters. Normal is approximately 100 to 115 centimeters. A mild bilateral Trendelenburg sign was present, indicating compensation for weak abductors. And during the step-up test, the patient struggled to complete more than 5 repetitions here. Lastly, in the neurovascular examination, sensations were normal, which ruled out any kind of radiculopathy. Reflexes are intact. Vascular assessment showed palpable distal pulses, overall giving no neurological deficits, indicating the pain is likely muscular or myofascial in origin. These two indices were used to assess patients' ADL, that is activity of daily living, and IADL, that is independence and activities of daily living. Summarizing, we have a 58-year-old female with upper back pain radiating to the neck, forearm and hand, being a known case of generalized body pain for 8 years, on regular DMARD therapy and has poorly controlled diabetes. She has postural errors and reduced range of motion in bilateral shoulder and hip, significantly on the right side. Pain is affecting sleep, daily household activities and walking ability. Multiple tender trigger points were present in upper limb, trapezius, supraspinatus and levator muscle, and in case of lower limb they were in adductors, vastus medialis and hamstring muscles. Her scores according to the Barthel index of ADL was 14 by 20, and in case of Cards index of independence of activities of daily living it was 4 by 6. So depicting a moderately functioning condition of ADL.
So
Now,
can I ask a question? It's like, do you do all this workup for all the patients who come to your OPD?
so
And
mostly
how much time does the full workup, including the indices,
on an
take
average
per
half an hour.
patient? Half hour
Half
per
an-
patient.
Yes, sir.
So, and it's done for all patients, particularly with chronic conditions.
Yes, sir. Specific to their complaints and symptoms, we do it because
Wonderful.
clinical examination is the core part of it.
Wonderful, wonderful.
Yeah. Now I would like to call Dr. Shilpa Maharia from Department of Physiology to provide expert insights into muscle physiology, which will help us to understand the case better.
Good morning, respected dignitaries. I am Dr. Shilpa Maharia from Department of Physiology. Central to the discussion of this case is the development of trigger points in the muscle. The development of these trigger points is closely linked to muscle, its structure and physiology. So let us begin our discussion with the normal muscle structure and function. A skeletal muscle, it contains many muscle bundles or fascicles. Each fascicle consists of large number of muscle fibers which are arranged parallel to each other. The structural unit of the muscle is muscle fiber, that is a single skeletal muscle cell known as a myocyte. The cell membrane of myocyte is known as sarcolemma and the cytoplasm is known as sarcoplasm. The sarcoplasm is filled with myofibrils that extend along the axis of the cell. Each myofibril in turn consists of cylindrical bundles of two types of myofilaments that are referred to as the thick and the thin filaments. The thick filaments, they are made up of myosin, and the thin filaments, they are made up of actin. Now the process that links the muscle's electrical signal to its mechanical contraction, it is known as the excitation contraction coupling. It involves the following steps. When a motor neuron generates an action potential, it travels down its axon to the neuromuscular junction. The action potential will open the voltage gated calcium channels in the nerve terminal, so the calcium influx will be there, which further causes the synaptical vesicles to release acetylcholine into the synaptic cleft. This acetylcholine further binds onto the receptors on the motor end plate, and the action potential will travel down the sarcolemma and down the T-tubules. Calcium is then released from the sarcoplasmic reticulum in response to the change in voltage. There is the release of the calcium. This calcium then further binds onto the troponin C. Troponin C, as such, binding of this calcium to troponin C will uncover the myosin binding site on the actin. Myosin head, it has two heads. At one side ATP is attached, so the myosin ATPase will hydrolyze this ATP into ADP and inorganic phosphate. Release of this inorganic phosphate will trigger the myosin head to pull the actin filament towards the center of the sarcomere, and this is the power stroke, after which ADP is released at the end of the power stroke. Now a new molecule of ATP will bind onto the myosin head. Binding of ATP causes myosin to detach from actin. So this ATP is required to release the contraction and the muscle enters into the relaxation phase. Now, after understanding the skeletal muscle, we should understand what are the trigger points. A trigger point, it is a hyper-irritable spot which is associated within a taut band of a skeletal muscle. The common causes are muscle overload, poor posture, injury, trauma, lack of exercise, nutritional deficiency, and sleep disturbances. So the pathophysiology of the trigger point. Whenever there is a muscle overload or trauma, it will cause motor end plate dysfunction, after which it causes the excess acetylcholine release at the neuromuscular junction, which leads to sustained contraction of the sarcomere, further resulting into local ischemia and hypoxia. Because the contracted muscle fiber, they will compress their own microcirculation. Reduced blood flow will diminish the oxygen delivery and limit the ATP production. Since ATP is required for the muscle relaxation, so this produces an energy crisis whereby the muscle cannot break the actin-myosin bond, remaining contracted. Sustained sarcomere contraction in the small segments, it is known as the contracture knots. This contracture knot will further pull on the surrounding tissue, creating the taut bands, which will lead to the formation of the trigger points and which are palpable in the clinical examination in the patient. Now I would like to call Dr. Ragdhara Mishra to carry the presentation further.
So after having a detailed discussion on history, examination and concepts of muscle physiology, we can evaluate the patient's symptoms with the help of this flowchart. Such patients usually present with pain, weakness, gait disturbances, sensory symptoms and paresthesias. As a patient had no sensory loss on examination, so we can classify this category into generalized symptoms with weakness, generalized symptoms without any weakness and focal symptoms. Discussing the possible causes in this category, under generalized symptoms with weakness, we can have motor neuron disease, myopathies, which could be due to any inflammatory, metabolic or toxic causes, neuromuscular junction disorders like myasthenia gravis or Lambert-Eaton syndrome. Generalized symptoms without any weakness can have myofascial pain syndrome, fibromyalgia and polymyalgia rheumatica. And under focal symptoms, we can have multifocal motor neuropathy, radiculopathies, which could be cervical or lumbar nerve root compression causes, entrapment neuropathies like carpal tunnel syndrome, cubital syndrome or any impingement syndromes, mononeuropathy and musculoskeletal disorders. So with the information we have so far, we can have differential diagnosis of either myofascial pain syndrome, fibromyalgia or polymyalgia rheumatica. Now I would like to call Dr. Himanshu Ahuja to carry forward the presentation.
Based on the previous discussion, let's move towards the investigations for the given case. The investigations performed included blood tests including CBC, blood sugar levels, HbA1c, renal function test, rheumatoid factor, vitamin B12 and D3 levels, ESR and CRP. Radiology included a shoulder ultrasound and MRI of cervical spine. The CBC showed microcytic anemia with significant eosinophilia, while other counts were largely normal. The patient's random blood sugar was 292 mg per deciliter, HbA1c 8%, indicating poor glycemic control. Renal function tests were essentially within normal limits. The RA factor was normal, B12 was in high normal range, while vitamin D3 was low at 26.3 nanogram per ml, indicating insufficiency. The ESR and CRP were elevated. ESR is 24 mm per hour and CRP 18.44 milligram per ml. The USG of trapezius shows a hypoechoic area. With a trigger point or contracture knot. This supports the clinical diagnosis of myofascial pain. The MRI shows no loss of normal cervical lordosis, likely due to paraspinal muscle spasm, mild degenerative changes with small osteophytes and diffuse disc bulge at C6, C7. Now I would like to welcome Dr. Ankit Beniwal from Department of Medicine to continue the presentation.
Good morning, everyone. Myself, Dr. Ankit Beniwal from the Department of General Medicine. I will now be carrying forward this conversation. So, we have a 54-year-old female presenting with complaints of upper back pain with associated neck pain, fatigue, and functional limitation during daily activities. The patient was referred to general medicine in view of low HB and raised HbA1c with a hemoglobin of 9 gram per deciliter, a platelet count of 5 lakh, MCV of 68 femtoliter, a red cell distribution width of 15.6%, a vitamin B12 level of 703 picogram per ml, HbA1c of 8%, and a vitamin D3 levels of 26.3 nanogram per ml. Now, the patient has a medication history of methotrexate, hydroxychloroquine, intermediate NSAIDs, steroids, and proton pump inhibitors. Patient also has a history of type 2 diabetes mellitus for which she is not taking any medications, a history of repeated episodes of anemia, and history of gastritis. On examination, conjunctival pallor was present. The following additional investigations were advised and the results were as follows. Serum iron of 20 microgram per deciliter, serum ferritin of 9 nanogram per ml, and a total iron binding capacity of 600 microgram per deciliter. With a normal retic count of 1.5%, the peripheral blood film showed microcytic hypochromic RBCs with anisoperculocytosis. So we have a diagnosis of iron deficiency anemia with type 2 diabetes mellitus. The patient was advised for iron supplementation in the form of ferrous ascorbate and folic acid.
Did you try to find out what was the cause of the iron deficiency? Like, obviously,
Yes, sir.
there has to be a reason, no?
Sir,
You could think of an anemia of chronic infection, inflammation in this patient, but that would be normocytic, normochromic,
Yes,
or because of lots of oral medications, non-steroidal anti-inflammatory agents, and history of gastritis, the patient might be having occult blood loss in the stools.
Yes, sir.
But if you have a diagnosis of iron deficiency anemia, you have to determine or try to determine the cause. Agreed?
Yes, sir. The patient has a history of PPI intake on a regular basis, which can cause the decrease in pH, which can hamper the absorption of iron, sir. Also, the patient has a history of poor oral intake due to fatigue and lethargy. Also, sir, the ferritin levels are normal in this patient, so we can it can help us rule out in the anemia of chronic disease.
I think the ferritin levels are below normal, no? And
Sir,
that is
below normal, sir.
one of the indicators which confirm presence of iron deficiency anemia.
Yes, sir.
Patient has a history of steroid
Yes, sir.
use. So did you work up for osteoporosis?
No, sir, not from my side.
That should be included with back pains and fibromyalgias.
And I think as a bare minimum stool examination तो इसका कराना ही चाहिए था for occult blood, right?
So,
Possibly, yes.
so
And why did you not think of IV iron in this patient?
sir, because the patient has mild to moderate anemia, not severe, and she's not in need of, she's not having any active bleeding or any acute symptoms, sir. So she was started on oral medication. The treatment of anemia was iron supplementation was added in the form of oral ferrous ascorbate and folic acid. She was also advised for a repeat CBC after 2 weeks. For diabetes, she was started on oral hypoglycemic agents with a combination of metformin and glimepiride. She was also advised for lifestyle modification and a regular random blood charting. Now I would like to invite Dr. Himanshu on the stage.
So moving towards our diagnosis of myofascial pain syndrome. Myofascial pain syndrome is a common but often misdiagnosed cause of muscle pain. It occurs due to trigger points, tight sensitive knots within muscle that create local or referred pain. The condition develops when muscle fiber contract excessively in the form of trigger points. They may be active or latent. Typical causes of overuse, poor posture, repetitive strain or minor injuries. Once trigger points are identified, the myofascial pain can be effectively treated. The trigger point types: active trigger points cause spontaneous pain, reproduce the patient's symptoms, and latent trigger point often not patient is uncomfortable but when they are pressed, the pain is reproduced and can cause restriction of movement and stiffness. The pain phenotypes in myofascial condition doesn't always behave same way, so we have three types of phenotypes. The first is nociceptive pain, most common. It is localized muscle pain caused by tissue irritation and overload. Nociplastic pain, it is more widespread, caused by increased sensitivity of central nervous system, we call centralization. Fibromyalgia being prime example. And mixed type, where patient has feature both nociceptive and nociplastic pain. Chronic pain patient fall into this category. So knowing this helps understand the treatment part and create a holistic treatment approach. The importance, the chronic myofascial pain is highly prevalent. Research shows that 30 to 50% of patients in general medicine practice present with myofascial pain features. In specialized pain centers, this prevalence increases dramatically to 80 to 95%. In head and neck pain clinics, approximately 55% of patients demonstrate myofascial pain components. Despite this high prevalence, the condition is frequently misdiagnosed, being mistaken for fibromyalgia or other chronic pain disorders, contributing to substantial healthcare burden, including repetitive medical visits, unnecessary investigations, and ineffective treatments. The pain does not always correlate with imaging and laboratory findings, so they are sometimes labeled as psychosomatic, anxious, or exaggerating their symptoms. These statistics emphasize the importance of accurate identification of myofascial pain to reduce patient suffering and improve treatment outcomes. So the chronic myofascial pain, it has multiple roles in clinical presentation. It creates pain problems on its own, that is trigger points. It complicates existing pain problems when already there are other musculoskeletal or neurological condition. The pain trigger points can intensify pain, reduce function, and make overall condition appear more severe. And chronic myofascial mimic other pain disorders. Pain patterns from trigger points can resemble radiculopathy, joint pain, headache, pelvic pain, and even visceral pain. Together, these factors highlight why accurate identification of myofascial pain is essential. The diagnostic criteria. The first feature is presence of taut and palpable band within the muscle, emphasized during palpation. Second came exquisitely tender nodule located within center of taut band. The patient's recognition of current pain complaint, that is active trigger point, and unfamiliar one, that is latent trigger point. The final commonly included criteria is painful restriction in muscle stretch range of motion. So the management provided to the patient included the medical management. The disease modified anti-rheumatoid drugs were discontinued under the supervision. For symptomatic relief, short-term NSAIDs were prescribed. Vitamin supplementation initiated to address deficiencies. The patient was treated with trigger point release, particularly targeting trapezius and adductor muscle, where active trigger points were identified. Lifestyle modifications were emphasized, including ergonomic corrections for daily activities, stress management, and improving sleep quality. The patient underwent a structured physiotherapy program, including stretching, heat therapy, and postural correction. Together, these interventions formed a comprehensive treatment plan tailored to this patient's myofascial pain presentation. So the medical management initially given was methotrexate, dose decreased from 25 to 15 mg for gradual tapering. Gabapentin, nortriptyline, telmisartan, aceclofenac, paracetamol, tizanidine combination, baclofen, ferrous ascorbate, folic acid, and metformin, glimepiride. After initial medical management, after 10 days later, the intervention was done, where trigger point injection for bilateral trapezius trigger with methylprednisolone 40 mg and 3 ml, 2% lignocaine under local anesthesia bilaterally and sterile medical conditions. Injection Botox 60 international unit was given, 25 international unit in each trapezius. The intervention. The slide outlines the key steps and materials required for performing a trigger point injection. The patient positioning being sitting, prone, or supine, both important for comfort and accuracy, and depending on the muscle group involved, the procedure can be carried out. The appropriate needle selection is made, typically 25 gauge or 30 gauge, the long and short needle depending on depth of target muscle group. Various injection solutions, buffered lidocaine, procaine, botulinum, and others, and also standard procedural supplies. Also, 20 days after initial medical management, trigger point injection was done for bilateral adductor trigger release with phenol 5 ml, 6% bilateral obturator nerve block under local anesthesia. So the phenol nerve block. Phenol is a medicine that reversibly reduces the insulation, that is myelin, that coats the nerve, resulting a slowing of its message to the muscle it innervates. This allows the muscle to be less tight or stiff. The muscle is able to be more relaxed immediately and stays looser for about 6 months. After that, the nerve successfully recoats itself. The effect of medicine wears off. In botulinum, it is different from botulinum, which acts on the muscle, blocking the acetylcholine release. And the phenol nerve block works best on the big muscles such as bicep, hip adductors, and knee flexors, hamstrings. These muscles most often cause scissoring and crouching of legs and cause orthopedic problems of low back, hip, and knee. The phenol allows tight muscles to be more easily stretched, especially during severe painful conditions. So, for the post-injection care, the patient was advised that soreness was to be expected and should not be confused with failure of treatment. It usually lasts 3 to 4 days, and patient was advised to remain active. Strenuous activity was advised to be avoided for first 3 to 4 days after injection, and use of heat and not cold treatments. The complications of trigger point injection can be vasovagal syncope, skin infection, pneumothorax, needle breakage, hematoma formation, and contraindications to trigger point injection are local or systemic infection, allergy to the agents, acute muscle trauma, extreme fear of needles, relative being anticoagulant or bleeding disorder, dystonia, severe anxiety, and severe psych issues. After the intervention, the medical management was modified to the sodium alendronate was given, calcitrol, calcium carbonate, and zinc, vitamin D3. The levocarnated with mecobalamin, folic acid, and levocarnated with vitamin were given alternate days, and tablet atorvastatin and exercise as advised. Lifestyle modifications were suggested: the ergonomic adjustment for posture, improving sleep patterns, systemic factors managing comorbidities, fall prevention strategies, nutrition, balanced diet and hydration, stress management techniques, maintaining social engagement. The exercises advised include low mobility drills for range of motion, regular stretching program, strength training, balance training, walking program for endurance and safety. With the 3-month follow-up, the functional independence had increased with notable improvement in both Barthel index from 17 out of 20, CARTS index for instrumental activities dealing 5 out of 6. Blood sugar levels had normalized, the recent being RBS 80 mg per deciliter and HbA1c being 7.2%. The mobility have improved. The patient is now able to climb up and down the stairs without difficulty. Now I would like to welcome Dr. Sonu sir to continue the presentation.
There were not much research till date on management of epidemiology and management of myofascial pain, but there are few articles on the diagnosis and treatment. Most of these management options are based on only physiotherapy. So our take-home message is: always differentiate inflammatory arthritis from regional pain syndrome. That myofascial pain may mimic arthritis condition, especially when accompanied by mild elevation or elevated ESR, and people should always underestimate the severe pain a muscle can cause. And lastly and most important is maintain healthy posture is the foundation for healthy living. I especially thanks Department of Medicine, Mentor and Management, CCR Review Committee, Department of Physiology, Department of Medicine, MGM staff, patient and family. Thank you.